Most people believe that cholesterol is the main cause of heart attacks. Check your cholesterol. Lower your numbers, eat less fat, take the medication. That is the framework most seniors have been given for decades, and for a long time it was presented as settled science. But after 28 years of working with cardiac patients, men and women who did everything right, kept their cholesterol exactly where their doctors told them to, I have seen something that does not fit inside that framework. I have seen patients with excellent cholesterol numbers have heart attacks, not occasionally, regularly, and I have seen patients with elevated cholesterol live into their 80s and 90s without a single cardiac event. That gap led me, and a growing body of cardiovascular research, to look harder at what is actually driving heart attacks in seniors. There is a process happening inside your arteries right now. Silently, without symptoms, without a number on any blood panel most people check. That is a far stronger predictor of cardiac events in seniors than cholesterol alone. It is driven by daily habits most people would never connect to their heart. Most seniors are not being told about it. Most are managing the wrong risk, because the real cause of most heart attacks in seniors is not what you have been told. And once you understand what is actually happening inside your arteries, everything changes. By the end of this video, you will understand the true number one driver of heart attacks in seniors, what it is, how it works, and what you can do about it starting today. No prescriptions, no complicated protocols, 5 specific daily actions, each one directly targeting the real mechanism at work. I am also going to show you how to check whether this process is already active in your body, using a simple test that most people have never heard of, but that is available through any standard blood panel. And I want to hold one thing back for now. The single, most powerful daily action on this list is not a food, not a supplement, and not an exercise. It is something almost every senior already does every day, just not in the way that protects the heart. I will cover it at number 4, but first, let me show you what is actually happening inside the arteries of seniors who have heart attacks, and why cholesterol is only part of the story. Picture the water pipes in an old house. Over the years, the inside walls of those pipes develop a rough, uneven texture. Deposits form, the flow of water narrows, the pipes still work, but not as efficiently as they once did. Now imagine that the rough patches on those pipe walls are not just deposits. They are inflamed, hot, swollen, unstable. And instead of sitting quietly against the wall, they are vulnerable to cracking open. When one of them ruptures, the body sends in repair material to patch the break. That repair material, a clot, can grow large enough to block the pipe. Entirely, that is a heart attack. Here is the critical detail most people are never told. Cholesterol does not cause the rupture. Inflammation does. Cholesterol is present at the site. It is part of the plaque that builds up in the artery wall, but it is inflammation that destabilizes the plaque. It is inflammation that makes the deposit fragile and prone to breaking open. It is inflammation that triggers the clotting cascade that blocks the artery. An artery full of stable, non-inflamed plaque is far less dangerous than an artery with smaller deposits that are actively inflamed. This is why some people with high cholesterol never have a heart attack. Their plaques are stable, and why some people with normal cholesterol do. Their plaques are inflamed. The driver, in both cases, is inflammation. Chronic, low-grade, systemic inflammation, the kind that produces no obvious symptoms, no fever, no pain, quietly eroding artery walls and destabilizing plaques over months and years. And in seniors, this type of inflammation is driven by 5 specific modifiable daily factors. Here they are. In 28 years of cardiac practice, the shift in how the medical community understands heart attacks has been significant. When I trained, cholesterol was the dominant model. Lower the LDL, reduce the risk. It was clean, it was measurable, it was teachable. But the clinical picture was never that clean. The patients who troubled me most were not the ones with high cholesterol. They were the ones with normal cholesterol who showed up in my operating room anyway. Men and women who had done everything they were told and still had a cardiac event. Over time, the research caught up to what many cardiologists were observing. The inflammatory model of heart disease, the understanding that chronic arterial inflammation, not cholesterol alone, is the primary trigger of plaque rupture, is now well supported in cardiovascular literature. What changed my practice most was not a new drug or a new procedure. It was understanding that the question was not how high is the cholesterol, but how inflamed are the arteries. Those are different questions with different answers. Today, I want to give you those answers. What most people don't realize is that chronic inflammation is not random. It is driven by specific daily inputs, things you eat, how you move, how you sleep, how much stress your body is carrying, and every one of those inputs can be changed. Here are the 5 most powerful ways to reduce arterial inflammation, starting today. Let me ask you something. When was the last time you thought about bread, white rice, or packaged snacks as an inflammation risk? Most people think about those foods in terms of weight or blood sugar. Very few think about what they do to artery walls. Refined carbohydrates, white bread, white rice, pasta, crackers, pastries, most breakfast cereals, are digested rapidly, causing a sharp spike in blood sugar. That spike triggers a corresponding spike in insulin. And repeated, frequent insulin spikes drive one of the most reliable triggers of systemic inflammation we know of. Think of it this way. Every time blood sugar surges, the body responds with a kind of internal fire alarm. The cleanup crews, immune cells, rush to manage the disruption. Over time, with repeated alarms, those immune cells begin to embed themselves in artery walls. They become part of the plaque, they make it unstable. This is the sugar-inflammation artery connection, and it is more relevant to seniors than almost any other age group because insulin sensitivity naturally declines with age, meaning the same refined carbohydrate load triggers a larger inflammatory response at 70 than it did at 40. I've had patients dramatically reduce their inflammatory markers, measurable on a blood test within 8 to 12 weeks, simply by replacing white bread with whole grain alternatives and reducing their daily sugar. Intake: no medication, no dramatic diet overhaul, one substitution, repeated consistently. What to do? Replace one refined carbohydrate per day with a whole food alternative. White bread becomes whole grain sourdough, white rice becomes brown rice, a packaged snack becomes a handful of walnuts. One change, sustained for 12 weeks, then test your CRP, the standard blood marker for inflammation, and see where your numbers move. Micro warning: if you are managing diabetes or on insulin-regulating medication, discuss dietary changes with your doctor first. Let me ask you something. What do you typically do in the 30 minutes after dinner? For most people, sit down, watch television, rest, understandable. But it may be one of the most inflammation-promoting habits a senior can have. The period after a meal is when blood sugar peaks. That post-meal spike is one of the most significant daily drivers of the insulin inflammation cycle. Sitting still allows blood sugar to remain elevated far longer than if the body is gently moving. A 20-minute walk after eating, not brisk, not vigorous, just comfortable, activates the muscles of the legs and lower body, which draw glucose out of the bloodstream and use it for movement. The blood sugar spike is blunted, the insulin response is smaller, the inflammatory load on artery walls is reduced. I've seen post-meal blood sugar readings drop by 20 to 40 points in patients who began a consistent 20-minute post-dinner walk with no other dietary changes. For arterial inflammation management, that is a meaningful shift. What to do? After your largest meal, walk for 20 minutes at a comfortable pace. 5 evenings out of 7, give it 8 weeks. Micro warning: if you have balance concerns or joint pain activated by walking, consult your doctor first. Now, what I'm about to share next is something most doctors don't spend nearly enough time discussing with senior patients. Action number 4 on this list is the one that surprises people most. Because it has nothing to do with food and nothing to do with exercise. It is something you already do every single day, but the way most seniors do it is actively driving arterial inflammation. And once you understand why, you will never think about it the same way again. Stay with me. Let me ask you something. When you think about managing heart health through diet, do you think primarily about what to remove? Most people do. That is only half the equation. Omega-3 fatty acids, found in fatty fish, walnuts, flaxseed, and chia seeds, do not just reduce inflammation. They actively resolve it. They shift the body's chemistry away from pro-inflammatory compounds toward those that repair and restore. In the context of arterial health, omega-3s do something specific. They help stabilize existing plaques. They reduce the likelihood of the inflammatory rupture that triggers clotting. They make the danger less dangerous. I've had patients add 2 servings of fatty fish per week and come back 3 months later with measurably reduced inflammatory markers and improved arterial function. The omega-3 effect is real, clinically significant, and available without a prescription. What to do? 2 servings of fatty fish per week, salmon, sardines, or mackerel, covers the baseline. On non-fish days, a tablespoon of ground flaxseed in oatmeal or yogurt, or a small handful of walnuts with breakfast. For supplements, discuss 1 to 2 grams of combined EPA and DHA daily with your doctor. Micro warning: high-dose fish oil can interact with blood thinners. Consult your doctor if you are on warfarin or similar medication. Let me ask you something. How often do you think about your sleep as an inflammation management tool? Probably never. Most people think about sleep as rest, something the brain needs. But sleep is one of the most powerful regulators of systemic inflammation the body has. And disrupted sleep is one of the most reliable triggers of chronic arterial inflammation we know of. During deep sleep, cortisol drops, blood pressure falls, and the body repairs the endothelial lining of blood vessels, clearing the inflammatory byproducts that accumulate during waking hours. When sleep is fragmented or cut short, that repair process is interrupted and inflammatory markers rise within a single night. In seniors, this relationship is especially pronounced. Deep sleep becomes harder to achieve with age. The inflammatory cost of one poor night is higher at 70 than at 40. Chronic poor sleep in someone over 65 is one of the clearest drivers of progressive arterial damage that cardiac medicine has identified. I now ask every senior patient about sleep as a standard part of their cardiac review, not as a secondary question, as a primary one. The connection between sleep quality and inflammatory markers in this age group is that consistent. What to do? Target 7 to 8 hours in a consistent window. 1. Same bedtime and wake time every day. Keep the bedroom between 65 and 68 degrees. Eliminate screens 45 minutes before bed. These are not comfort suggestions. They are arterial health interventions. If you snore heavily or have been told you stop breathing during sleep, ask about a sleep apnea evaluation. Untreated sleep apnea is one of the most overlooked drivers of cardiac inflammation in older adults. Let me ask you something. When did you last have your C-reactive protein tested? If the answer is never, or if you are not sure what C-reactive protein is, you are not alone. Most seniors have their cholesterol checked routinely. Very few have their CRP checked with the same regularity. C-reactive protein, or CRP, is a blood marker that rises in the presence of systemic inflammation. A high-sensitivity CRP test, available through any standard blood panel, typically at low or no additional cost, gives a direct reading of how much inflammatory activity is currently present in the body. In cardiovascular research, high-sensitivity CRP is one of the strongest predictors of cardiac events in seniors. In many studies, a stronger predictor than LDL cholesterol alone. A reading below 1.0 milligrams per liter is considered low risk. Between 1.0 and 3.0 is moderate risk. Above 3.0 indicates elevated inflammatory activity and warrants conversation with your doctor. Knowing your CRP number changes how you understand your cardiac risk. It shifts the conversation from cholesterol management, which is only part of the picture, to inflammation management, which is where the real risk often lives. The most important thing I can tell any senior who is serious about protecting their heart is this. Ask your doctor for a high-sensitivity CRP test at your next visit. One number, it tells you more about what is happening in your arteries right now than almost anything else on a standard panel. What to do? At your next doctor's visit, request a high-sensitivity CRP test alongside your standard cholesterol panel. If your CRP is elevated, use that number as the baseline and measure it again in 12 weeks after implementing the actions in this video. The changes are trackable. The progress is real. Every action we have discussed today targets the same root cause, chronic arterial inflammation. Inflammation destabilizes plaques, destabilized plaques rupture, ruptured plaques cause clots, clots cause heart attacks. Cholesterol is part of the picture, but it is not the trigger. Inflammation is the trigger, and inflammation is driven by the daily inputs your body receives. What you eat, how you move after meals, what you consume for anti-inflammatory nutrition, how well and how consistently you sleep, and whether you are measuring the right markers to understand what is actually happening in your arteries. Every one of the 5 actions we covered today directly reduces inflammatory load on the arterial wall. The refined? Carbohydrate reduction lowers the insulin inflammation cycle. The post-meal walk blunts the blood sugar spike. The omega-3 intake shifts the body's chemistry toward resolution. The sleep optimization restores the nightly repair process. And the CRP test gives you a real, measurable window into the process itself. This is not an alternative to conventional cardiac care. It is the part of conventional cardiac care that does not get enough time in a 15-minute appointment. Inflammation is the mechanism. These 5 actions address it directly. Let me tell you about a patient I will call Edward. Edward was 71. He came to me after his second cardiac event despite having well-managed cholesterol for over a decade. He was on a statin. His LDL was in the target range. He exercised moderately. He did not smoke. By every standard metric, he was doing everything right. But when I reviewed his full picture, CRP, sleep history, dietary pattern, daily routine, a different story emerged. His high sensitivity CRP was 4.2, significantly elevated. His diet was low in fat but high in refined carbohydrates, crackers, cereals, packaged foods. Because he had been told to reduce fat for years, he slept 6 inconsistent hours a night and had never been evaluated for sleep apnea despite heavy snoring. His cholesterol was managed, his inflammation was not. We worked through each of the 5 areas: dietary adjustment, post-meal movement, omega-3 intake, sleep evaluation, which revealed moderate sleep apnea, subsequently treated, and regular CRP monitoring as feedback. Over 6 months, his CRP dropped from 4.2 to 1.1. His blood pressure normalized. At his 12-month review, he said, "Why did no one tell me about inflammation? I spent 10 years managing my cholesterol and nobody ever mentioned this. If I had known what was actually driving the risk, I would have done things differently." That question is the reason this video exists. Let me make this simple. 5 actions to reduce arterial inflammation and address the real #1 driver of heart attacks in seniors. Action 1. Replace refined carbohydrates. Swap 1 refined carb per day for a whole food alternative to reduce the insulin inflammation cycle. Action 2. Walk 20 minutes after your largest meal. A comfortable post-meal walk blunts the blood sugar spike that drives systemic inflammation. Action 3. Add 1 omega-3. Rich food daily, fatty fish twice a week, plus ground flaxseed or walnuts on other days to actively resolve arterial inflammation. Action 4. Protect sleep quality and consistency. 7 to 8 hours, same window nightly with a cool, dark room. Sleep is the body's primary arterial repair cycle. Action 5. Know your CRP number. Request a high-sensitivity CRP test at your next visit. This single number tells you more about your true cardiac risk than cholesterol alone. 5 actions. That might feel like a full agenda. It is not. Pick one. If I could tell you to start with just one, it would be Action 5. Ask for the CRP test. Because until you know your number, everything else is guesswork. The CRP test costs almost nothing, requires no lifestyle change, and gives you the most important piece of information about what is actually happening in your arteries right now. One conversation with your doctor, one number, everything else follows from there. Start there. Then, when you are ready, add one more action from this list, not all 5 at once. One, then another. Sustained, consistent change over months is what moves the needle on inflammation, not a perfect week followed by nothing. I want to hear from you in the comments. Have you ever had your CRP tested? And did your doctor connect it to your cardiac risk? Leave your answer below, because your experience might be exactly what someone else in this community needs to read before their next appointment. And if this video shifted something for you, if it gave you a question to ask or a number to check that you did not have before, please share it with your spouse, with a friend managing their cholesterol, with an adult child who is helping an aging parent navigate their cardiac health. The information in this video is not complicated, but it is not reaching enough people. Help change that. Subscribe to this channel for weekly senior health guidance, honest, research-grounded, and explained in plain language by a doctor who has spent 3 decades watching what actually protects the heart and what does not. Everything in this video is for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. The information shared here is not intended to replace or contradict the guidance of your cardiologist or primary care physician. Cholesterol management remains an important part of cardiac care. This video is intended to add to that conversation, not replace it. Do not stop or adjust any medication, including statins or blood pressure medication, based on anything you have heard here. Always consult your doctor before making changes to your treatment plan. if you are experiencing chest pain, shortness of breath, or any cardiovascular symptoms. Seek medical attention immediately. Your heart health is a partnership between you and your medical team. This video is one input into that partnership, not the whole of it.